Um, DICE, drug-induced sleep endoscopy. Drug-induced endoscopy is a diagnostic tool to assess upper airway of snorers and OSA patients in conditions which mimic natural sleep. With the aid of sedation, the upper airway can be observed dynamically to allow sleep surgeon to have an accurate idea of what is happening during sleep. CTRA sedation is also under sedation is also possible, but in days we can do any maneuvers or a change in position. But in CT or MRA, this maneuvers or positional change cannot be done. So DICE is the preferred diagnostic tool of option for OSA. Technique to achieve a sedation level that resembles natural sleep to obtain reliable DSE findings. Where is this performed? It is usually performed in a room where all resuscitation equipments are available. Monitors are all AS standard monitors, including ECG, pulse oximeter. Bispectral index can be used. It is highly recommended. And the sedation level of this is between 70 and 50. The patient should not respond to a verbal stimuli. That should be the level of sedation. If there is light sedation, airway can be underestimated. If there is deep sedation, the airway can be overestimated. And thinnest possible fiber endoscope can be used with working channel to aspirate if any secretion is present. The drugs used based on literature, midazolam, propofol, dexmedetomidine, ketamine, remifentanil can be used alone or in combination to achieve ideal level of sedation. But based on evidence proven, sedation with propofol using TCI pump, it demonstrates a natural sleep. The duration is mostly between 15 and 30 minutes. Since the duration is very small, all the stages of sleep cannot be achieved in this. The REM sleep cannot be reproduced by this level of sedation. Only stage 2 sleep can be achieved with DICE. The sedation should be achieved slowly until the BIS is 50. The position and maneuvers is usually done in a supine decipitous position. If lateral position for those patients who sleep in lateral position. Maneuvers, if the mouth is open, the chin lift maneuver can be done to close the mouth. S-march maneuver is to gently pull the mandible forward. This can also be done. So what are all observed? First, to assess the upper airway, the patient should be snoring. Using fiber optic endoscopy, the is open, the tongue base and epiglottis, any collapse is there, it can be seen. The soft palate is usually observed for 1 to 2 minutes, and the scope is advanced downward to observe the rest of the upper airway. Now, what are the events noted is we have to note for the areas of vibration, areas of collapses, and also the shape of collapses can be noted. So based on all these observation, the recommended classification is called Vogt classification. The structures seen as velum, oropharyngeal wall, O for oropharyngeal wall, V for velum, T for tongue base, and E for epiglottis. All these structure, the degree of obstruction and configuration are studied. DICE has got a potential role in determining treatment option for OSA. Uh, um, like mandibular advancement device, the mandible is manually advanced by 5 to 10 millimeter during DICE. If the upper airway caliber increases, it predicts that mandibular assist device therapy will be helpful. And it is also indicated for positional therapy, like if any positional change is corrected through is if upper airway does not collapse in certain position in DICE, it means that the patient positional therapy can be given, and also any surgery can also be suggested after. If treatment If the OSA patient is on CPAP, then the DICE is not needed. If the patient has a CPAP failure, then the DICE can be recommended. The contraindication for DICE is any ASA4 patient, pregnancy, and any history of allergy for all these for all the drugs used. How is the report of DICE written is, one is the level of sedation is noted, the lowest oxygen saturation is noted, the drugs used for sedation is also noted, the upper airway finding, that is the vibrations, the shape of the collapse, and the areas of collapse are noted. Then any maneuver is done or not to perform DICE is also noted. That's it, sir.
Yes.
Thank you, sir.
So this is investigation, as we rightly said, the drug-induced sleep endoscopy is an investigatory tool, mainly for people with the OSA who are not fully relieved of the problem with the conventional CPAP or BiPAP machine. Normally, we used to do what is called the overnight sleep study or the observation of patient in his natural sleep. So that took a long time. We have to use a video camera, attach so many monitors to the patient to find out each and every function. So it's a more cumbersome way of doing it. But still, that is much more safer because we are doing it with a patient who has his natural sleep and identify the degree of obstruction in the treatment required. But if in spite of that and giving the treatment in the form of CPAP or BiPAP, if patients are not comfortable and they are not able to get relieved of this problem, then we have to identify why there is a failure of this conventional CPAP or BiPAP. That is done. You cannot do it in a conscious patient because in a conscious patient, the upper airway will be open. They can maintain the tone and the pharynx will be open. The tongue will not fall back, so they will not have any issues. But on the contrary, once you induce sleep, make them go into a artificial state of sleeping or mimic the natural sleep, then you can find out where exactly the obstruction occurs, whether it is at the tongue base level or at the pharyngeal muscle level, and that can be easily noted by passing an endoscope nasally in these patients, and that is the reason why we have introduced the sleep surgeons or ENT surgeons have all introduced this as a part of the diagnostic tool, and Sanjutha has covered most of the points. So I'll just show my